We are live. Have a look at the participants. Give it a minute or so. Not often we broadcast slightly before the time. It's going up a little slowly. Let's make a start. Welcome everybody to this webinar on community health networks, or known as localities. We have a great lineup this evening, and let us start with our karakia before we get into our introductions. Please join us.
Ko te tirito te hara keke, kei he tuku reo e ko. Ki atu au ki a koutou, he aha te me nui hei. Ora aki tuku reo, ka ki mai koutou, e tangata, a ako ko wai, tuturu waka maua ki a tina, homi e, hui e, tai ki e.
Thank you, Cherie. Ko tarara te monga, ko waikanai te awa, I tipu ake aho I Gateshead, England, ko Wayne Maxwell takutane, no wairarapa ai, ko Flynn Roa, ko Tara aku tamariki, ko Amajit Maxwell aho, tēnā koutou, tēnā tātou katoa. Welcome everybody, my name's Amajit Maxwell and I'll be your host this evening, and I'm the Programme Director for the Healthcare Home Collaborative, supported by my small team, Kirsten and Jess, and a big shout out to our network of leads and change facilitators that actually help us do the mahi. Let us get into the introductions for our panel. Rachel, could I hand over to you to do your introduction?
Yeah, so kia ora koutou, nā Rachel Haggerty Tākaungawa. I am the Director Strategy Planning and Performance at Kaplan Coast and Hutt Valley District Health Board. It's a pleasure to be here.
Thank you, Rachel. Cherie.
E ngā mātou waka o te motu, tēnā koutou, no mai, haere mai, te kaupapa o te pō, ko Wakanai te awa, ko Te Ati Awa ki Whakarongotai te marae, ko Cherie Tukuingawa. I am the Deputy Chair of the Te Ati Awa ki Whakarongotai Charitable Trust Board. Welcome tonight. Hope you can take a little bit of something away. We're all here to help you understand where we've gone and where we are when along our journey. Kia ora.
Kia ora. Thank you, Cherie. And Chris.
Kia ora. Ko Chris Tākaungawa. I'm the Medical Director of Dora Compass Health, but also a GP at Horakai on the Kapiti Coast, and therefore have an involvement in the Kapiti Health Network in several levels, and we can talk about that as time goes on. So welcome everybody.
Thank you, Chris. And Paul, all the way from Chicago, we really appreciate you joining us tonight live, as I know it's very late there. So thank you. So over to you.
Hi, I'm Paul Schmitz. I'm in Milwaukee, Wisconsin, which is near Chicago, and it's right now Tuesday night at 11:30 p.m. And great to have a chance to visit with you all tonight, even briefly. Enjoyed staying up for it. So look forward to talking to you soon.
Thank you. So what we're hoping to, or what we're planning to cover this evening is Rachel covering the background of community health networks and the proposed future as part of the Health and Disability Systems Review and the Capital and Coast District Health Board's vision that they've had for some time around networks, and also to provide a bit of an overview of their current MAHI, their work within the Kapiti Community Health Network. Cherie, having worked in the heart of the community alongside others and as an iwi representative, will share the importance of partnering with iwi and the community, focusing on the benefits of using Māori models of care as a foundation for networks. And Chris, in his role as a GP and medical director, will share his clinical leadership perspective and how this supports networks, or this can support networks. Included will be a bit of a case study that is getting off the ground as part of the Kapiti Community Health Network. And Paul, with his vast knowledge and experience, will provide an overview of the collective impact framework and the importance of leadership and culture in making positive shifts in the community. At the very end, I will do a very quick preview of the toolkit that is being developed to support networks. And we'll have Q&A, time for Q&A, so and a bit of a call to action. So you can see the hopefully see the Q&A button at the bottom of your screen. So by all means, start putting questions through as early as you want to. As soon as they come into your head, pop them through, and then we'll field those a little later once we've had our presenters share their wisdom with us tonight. So sit back, relax, and I'm going to hand you over to Rachel.
Kia ora everyone. I've already introduced myself, but what I wanted to do is give you, as Amajit has said, an overview of what we've been seeking to do here at Capital and Coast DHB and now in the Hutt Valley DHB with the implementation of a thing we call our health system plan. The health system plan was written in about 2016, 2017. It's on our website for CCDHB if you want to see the entire plan. The plan is has a very simple premise, which is we need to think about the way in which we organise the system of service delivery and maximise the opportunity to support people based on who they are and where they live. And in its statement, it sounds very straightforward, but the plan has 4 pillars. It's about recognising that people need services that reflect their place in the life course and reflect their needs. And you'll see there that we talk about urgent and planned care, about children and long-term and complex care users. The other thing is about place, and we talk a lot about setting of care. So as there is different, this is different to the community in which people live, but the setting of care focuses on homes and residential care, our community health networks, which we're talking about tonight, and then our hospital settings. Also has a very strong focus on equity and around intensifying support for those who need more from the healthcare system to achieve the same equity in the outcome result. So when we, Amajit, if you could give me the flip to the next one, this conversation about settings is really important. When we wrote the health system plan and we were looking at what it is that we were trying to achieve, we recognised that we're a complex adaptive system, and we cannot be commissioning a system that is just about commissioning individual services. We actually needed to create places in which people could continuously improve, use things like collective impact technology, work together to move faster to better meet the needs of the communities that they serve. So these are the 3 settings that we've been working with now for several years with regards to developing our capability. We talk about the importance of information, we talk about what they're trying to be, and within the Community Health Network, it is designed to become the central organising point for patient care within communities. So it is sitting within a locality construct about the communities that we serve, but it is fundamentally about how healthcare providers can network together to deliver better care. And we recognise that to do that, we actually need to create a system that supports that network, that in the same way that we have systems that support how hospitals run, recognising that that PHOs have a particular role, but there is a much wider range of community health services in our communities. So one of the questions in this is about how does this relate to the Health and Disability System Review? We'd like to think that we were forward thinking with regards to thinking about this approach, but the Health and Disability System Review clearly thinks about how we create what people are calling now tier 1 services, but how we create that network approach to primary and community care. And the community health network is potentially a system and an organising system that enables us to deliver that tier 1 integration. It isn't about everything. Communities have their own strengths, their own capabilities, and their own contributions to look after their well-being, their families, their whānau, and their futures. But this is about how do we make sure that the delivery of services is coherent to that community, that when people step outside of their door, that is utterly consistent with the direction of the Health and Disability System Review. So what we have started to do is think about prototyping. And we have a very strong relationship with our primary health organisations here in the Kaplan Coast DHB. And that relationship has meant that we've been investing in the healthcare home model for several years now. And what we have identified is that in transitioning that funding as healthcare home has become an established and mature model across much of our community, is shifting that investment into community health networks. You cannot expect the infrastructure of a network to create itself. I think sometimes we are overly reliant on relationships, on people coming together and wanting to do the right thing, and not recognising that we actually need to invest in capability to lead, to look after, to nurture, and to build these networks in a way that they can actually deliver for communities. So we use the word prototype. We don't use pilots or projects, and we do that on purpose because prototyping is about establish something, get it up and running, figure out what's working, and continuously improve that with the intention of being successful. We do see our investment in the establishment of the Kapiti Community Health Network as an ongoing long-term investment. We're not setting up a little project, sort some things out and then leaving that. We see it as part of that long-term part of our infrastructure. So as you can see from the diagram there, it brings together a number of partners together, and that's really the beginning of our network. And you can flip to the next slide, Ajit. This is the original diagram that premised that we actually wanted to bring together all providers from all aspects. And the different colours there are saying at its core, it has healthcare homes, really effective, well-structured, primary care that is connected into its primary mental health, comprehensive diagnostics. We haven't quite got there yet. We have got there on primary mental health, building our relationships with the community health support. But then what it's saying in the black boxes, there's a whole range of child and family services that need to be networked in. And the green boxes, our older persons, our mental health, our residential care. And then the yellow box is working with people with complex and long-term conditions. And this really is about bringing together that range of providers. We talk about, you'll see there's a box there around social care providers. Social care providers are certainly part of the future and vision of community health networks. We have a saying here in Kaplan Coast DHB is that health needs to be coherent to make it easier for social networks to work with us. And that is the core of the service of community health networks, is to create coherency in the health system and to ensure that we can get the most out of the services that are delivered by people working together. So one of these things is why do this? The statements that are there are really important. But in the fundamentally, it's about building a platform for community integration that has perpetuity, that is stable, that is long-term, that has leadership, that has capability. And I'm sure we'll see when Paul talks about backbone organisations and the way in which collective impact works, part of this was also building capability that belongs to that community rather than belongs to the district health board, using that external capability to continuously inform itself. But fundamentally, we also see it as a place that, say, if we take the planned care initiative as a district health board, that it creates a really strong platform for us to really think about doing more in the Kapiti community. One of the reasons we chose Kapiti is it is relatively geographically isolated within the Kapiti Coast geographical environment, and being able to do more locally was really important, and this would give us a place in which to do that. So one of the things that I would like to say is that in establishing this, we have really strong support from our board and from our organisation through the health system plan, but we recognise as we needed to invest, we needed to say this was an important part of our long-term success. And we also should not do it ourselves. So we did have a long conversation about should the District Health Board be supporting community health networks. And we have found the partnership with our primary healthcare organisation, with Tōra Compass as the provider of the network leadership, has been really important. I will leave Cherie to talk about the importance of the iwi partnership, but one of the things we very clearly say is the iwi relationship has primacy. It is incredibly important in this work that mana whenua are able to hold the governance space with the District Health Board, working alongside the Community Health Network, if we are really to build that long-term partnership with mana whenua. So I'll stop there, and hopefully that's given you some context into the process of creating an environment that was open to community health networks, building on our success of the healthcare homes, recognising our relationship with iwi, and it is here for the long haul. This is not a project. This is a long-term investment in our community infrastructure.
Thank you, Rachel. That was awesome. And as you said, this has been a long time in the making and the plans that have been in place. So yeah, good on you guys for actually, being those early adopters. So thank you. Now, Cherie, do you want me to share them? Let's go straight into sharing the slide.
Yeah, please do, Amaja. Thank you, Rachel. Just leading into some of the questions that I have to answer. I think when we're establishing the network, what was really good was there was early engagement, early conversations, and that is pivotal for iwi to be able to express what their aspirations were. You need to ensure that the right people are around the right tables. Also define clearly what the purpose of the engagement is, which was really good from the onset. The DHB came out and they met, and then the PHO also met with iwi. So we were versed in what needed to happen. We were basically given the brief that go ahead, dream, do what you do best. You are experts. When it comes to collective impact, we do this naturally. So outline what the benefits are. It's really important what you want to achieve to get buy-in, and allow iwi the space to express their expressions and enable co-design to go on. Making available the resources to support those aspirations is a big part of it. And just by listening and being willing to change what traditional models of care or service delivery looks like, I think that's gone a long way in establishing relationships and going forward. So just moving on again, one of the main, and we've got a slide up here, which is the whānau ora slide. We go back, Jit, thank you. This is pivotal to how Te Aho Māori worldview is seen. And we've all heard of whānau ora. This is a really good platform to be able to start implementing that without being a whānau ora provider. So it's pivotal that you have, it's based on whanaungatanga, and whanaungatanga is the glue that supports whānau and relationships. it's the sense of belonging and inclusion, and it enables kaupapas to flourish. Relationships are based on trust and collaboration, and that's why I'm saying it's important to get in early. It's important to establish that. It's pivotal to success, actually. And it's at the heart of every community, is that sense of belonging and being connected and being empowered to be able to be directed and upbeat into where you need to go when you need it in a timely manner. So when it comes to understanding your community, it's really important that you have those discussions early, but it's also about getting that gut feeling. It's looking at all those sources of information that are available, both physical aspects, but it's also the histories that is really important, because in order to achieve the future, you must look back to the past and just see and acknowledge what actually happened there. And in the Te Aho Māori world, that's very important to us. So history tells a story and is able to, it's an enabler to be able to achieve success. So outcomes for whānau, what we really were concentrating on and what we really want to see is that whānau are empowered, they're engaged, and unmet needs are met both socially and health-wise. So, and they have access to culturally safe services. So if you just want to flick on, please, Amjit. When we decided to sit around the table, and we decided that the best model that we would give to the network would be Te Whare Tapu Whā. It's a model that everybody knows if you're in health, and it covers all 4 pillars. And it gives a really good view of what Te Aho Māori worldview is. And there are other models, but as Chris works for Hora Tapai, and a lot of the health system know Te Whare Tapu Whā. And it's a complex but simple model to be able to use. So Te Atiawa gave that model, or introduced that model into everything that the network does. And it also covers those different aspects of determinants of health as well. So we thought that was a great model to start using. So when it comes to an equitable approach, this is all set by the first stage when you sit down and you have those first conversations with Māori. It is part of the treaty where we've got partnership, protection and participation. To achieve an equitable approach, it's about coordinated and effective care. It's also including the social determinants of health in a whānau ora model, and that is the slide previous, but you can stay on that one, Amajit. So it's about connecting communities and empowering positive wellbeing choices for whānau. They must be at the centre of whatever we do. So again, they must receive good quality health services that are safe, effective and are whānau-centric, timely and effective. And not necessarily in the traditional model that we have. It's about being innovative and being able to be flexible and agile enough to offer services that are suited and are whānau-centric. Just about there. The approaches need to focus on the Māori strengths and assets and develop Māori-led incentives and initiatives, and they must be tailored to meet Māori need. So that is me. I just say the benefits of actually being in the network, Chris will go into. I think he's got some particularly good slides, some work that the Hora Tapai Health Services have been working on with the DHB and the PHO. So I will leave it to you, Chris. Kia ora.
Kia ora, Sherry. So I've got only one slide at the end, but I've been asked to talk about a number of things. The first is the value of clinical leadership. And I think clinical leadership is incredibly important here. One, I mean, this is a health focus, and although there are many determinants of health, and there are many things you could pull into the basket, if we lose the focus on high quality health care, we're going to miss the bus. It's sort of a part of credibility. It's part of getting buy-in from the other health providers in the area. So it doesn't really matter who we've got good relationships with or who we coordinate with if our health outputs are not good. So clinical leadership is really critical. One of the risks I perceive of a health network is the ability for the whole thing to collapse under the weight of expectation. This is all things to all people. We know that we're in the business of health. We know that there are other things that determine people's health around housing, around education. There's lots of other things. But for me, having that core of really good provision of healthcare and therefore good governance is actually critical to the success of this project. So we need to measure our outputs, and we need to be able to track what we've done and see whether what we're doing is making a difference. Are we getting some measurable improvement from what we're doing? That can be measured in many different dimensions, but we have to have good clinical care as the heart of what goes on. So clinical leadership, incredibly important. What have we done around that? We've got a clinical leader. We're setting up some peer groups using a Pegasus model. And so these peer groups are looking at data, and we're hoping to start feeding them some data from our healthcare home area. They are multidisciplinary, so they have nurses, nurse practitioners, pharmacists, and GPs in them. And I think there might be one Wellington Free ambulance officer attending one of them as well. So I think the clinical leadership side is incredibly important. And it doesn't really matter how good the relationships are. If people aren't getting better care, no one's going to buy in. The second question was whether the healthcare home model was a good model to build on. Yes, I think it's a great platform. At the risk of Amajit turning me off, I suspect it's probably not the only one, but it's a very good model. And particularly the elements of the healthcare home model that I think are important is the coordination that we've learned, cooperation with other services, so the MDTs. And it's been great to see the way that both the DHB have pushed their staff to get involved with the practices, and the way the practices have welcomed the community workers from the DHB. So those MDTs have been great, and they set the platform for us to be able to develop better coordination. I think the other things that have happened is that with the healthcare home model, we've got a more flexible idea of scheduling. We're not quite broken out of the 15-minute consult mode, but we are aware that some things take longer. And so we're getting a wee bit more flexible with our telephone assessment and triage, and providing time for the patient that is not just fitting into those narrow schedules. The third thing is the multidisciplinary team. And I think that's really critical. So GPs are now hopefully used to talking with pharmacists, nurse practitioners, nurses, both in their own practice and in the community. And the other thing is the lean aspect as well. And I think a lot of practices have actually picked up on that and have developed their processes really well. The next question I was asked was, well, what are the enablers of developing a community health network? And first one, I'd have to say a big shout out to the DHB, because I think they have entered this with some funding in a high trust way. And they have said, let's work together on this. And certainly this is not a PHO or general practice initiative. It's a cooperative initiative. And I think the DHB have provided both resource in terms of money, but also manpower and expertise that have actually facilitated this. So if you're listening to this from an area which you don't have a good relationship with the DHB, possibly the first thing is go and get a good relationship with your DHB, however you can. The second thing I think is good communication with the iwi, and it's been great to see the iwi being prepared to step up and get involved. And I think it's difficult sometimes for people to come into the health area. We speak a different language, we do things in a different way, and so all credit to the iwi for getting involved.
There are some other bits that I think are specific to Kapiti, and you can take these as you will, but I think there was a bit of a burning platform in Kapiti because we are so far away and we have an elderly population. We have a lot of people traveling into Wellington for services. So there's a bit of public groundswell giving a bit of impetus to local solutions. I think there's a need for a shared vision, and that takes a while to develop. Some clear problems to solve. Like we have the problem of older folk not being able to travel into Wellington. We have the problem of some people not receiving services. I'd say take time. It takes time to develop those relationships, especially those trusted relationships. I think the fact that we're a geographically discrete area is actually an enabler as well. We're not a homogenous population, but the geographical spread does have some implications for us. And then I think good data, understanding of the data, and a focus on equity are important as well. Those are my questions. And the last slide I'm going to bring up is just some projects that we've done. So I think it's a wee bit premature to say that we've been successful in this. We are on a good path and I'm optimistic, but we're just going to share one slide. So one of the things that actually came out of COVID was that there was a very large halfway house with over 100, about 110 patients in it, who would have created a problem if COVID had got in there. Unfortunately, it didn't. But it also brought their health needs to the fore. And so this is some data about them. These people have high and very high needs. They are transient often, and a lot of them were not enrolled in general practices. And you can see their long-term conditions were far more than the ordinary population. So this was a high needs group who weren't being serviced, not even enrolled in practices. So in collaboration with the DHB, we started a clinic at this site with a nurse practitioner, a nurse, and a health coach. Now, the good thing is both the nurse and the health coach are local Te Atiawa, and so they've got really good contacts into some of the people who live there. So that connection is really important. This is potentially a very exciting thing. These people go to the hospital 10 times more frequently than anyone else. They use the ambulance a lot, and we're hoping, although it's early days, hoping that we're going to make a difference there. So this is one of the success stories, one of the things that's come out as we've started talking to people and exploring what's going on in our neighbourhood. Got a couple of others that are interesting as well, but I'll leave you on that one because I think my time is running out. Amajit.
Sorry, I was still mute. Thank you, Chris. That was really, really, you know, interesting in terms of a very recent example. And yeah, I'm going to, in the interest of time, because it's midnight, 1 minute past midnight, where Paul is, I'm going to hand over to Paul for him to share his wisdom with us. And yeah, over to you.
Thank you, and good evening, everybody. It is late. I'm a little tired, but I'm happy to share a little bit with you all about my lessons in work in collective impact. I've actually made 2 visits previously to New Zealand to do this work with support of Inspiring Communities in Wellington and Mania King at the Ministry of Social Development and the Mackenzie Trust and some others who've brought me out a few times, been to many cities and enjoyed my visits very much. I'm going to share my screen here and let's go to here. So I serve both. I have my own company called Leading Inside Out, but also serve as senior advisor to the Collective Impact Forum, which is a global forum anyone can join and participate in that shares information, resources, and learning around the idea of collective impact. And I've been doing that work for several years. I've visited hundreds of efforts around the world and have kind of built a practice around that. And I'll speak just real briefly about what that means. First, I'm coming at you from America, but it's a new and improved America. We are getting better. I was looking at some New Zealand data today just to remind myself how much I loved your country, but also how much more sane you are. Just to give you a perspective, my city, Milwaukee, which is about 90 miles north of Chicago, over 100,000 people have had COVID, and over 1,000 people have died just in my city. In the course of the last year, we shut down a year ago. In a couple days, will be 1 year since we hit our moment when everything started shutting down. But we are on the mend, and right now over 60,000 people are fully immunized. Another 60,000 people have had their first shot. So we're on our way back, but definitely been a crazy period with all sorts of things. And I can tell you that there's many times where I've read the news and just dreamed of my time in New Zealand, which I love very much, and wished I was in a more sane place. But we are getting better. So I came to this work initially as part of the White House Council for Community Solutions. For 20 years, I led a nationwide organization in the US that did grassroots leadership development and community building in 25 cities across the country. And I was a member of something called the White House Council for Community Solutions, which was part of President Obama's Domestic Policy Council. And we were charged with finding how our community is solving problems. And a lot of people came to us with ideas of, here's this great program here or another great program here. Maybe we could take this to scale, and all these conversations about finding great models. And something was really gnawing at me about that. And it really hit me in April of 2010. The headline of my local newspaper was, we had the worst fourth grade reading scores for African-American children in the country. And that afternoon, I got a newsletter from the largest youth organization in the city boasting about all the outcomes they were achieving with the 15,000 children they served. And that disconnect really hit me. I thought, if we're achieving all these outcomes, and I thought of all the youth programs I knew, my kids were in the public schools and were in some of those programs. I thought of all the great work that was happening in our community and all the groups achieving outcomes to improve the lives and education of children. And I thought, how can we have all this great work happening, and at the end of each year, this is the result? And so I went back to our council and said, instead of trying to find great programs, could we find communities where the needle moved, where for a whole population, the crime rate's down, graduation rates are up, reading scores are up? Where are communities that have actually solved things? And as we began that exploration, this article came out in the Stanford Social Innovation Review called Collective Impact that coined the term. But I'd like to point out, they didn't invent collective impact. They were describing something that already existed and that they had found in several communities that had used. And I think Sherry talked about it kind of like organic. And I think that's true. I think it grew organically from people asking the same question: why do we have so much good work happening in our community, but when we add it all up, it's not solving the problem? And how do we connect ourselves in a way that we can do that? And as we did that exploration, one of the examples was actually in my city. Milwaukee, for over 20 years at that point, had been number 1 or number 2 in the country for teen pregnancy. At the point that they began this project in 2006, the Milwaukee rate of teen pregnancy was 2.5 times the national average. So 250% of the national average. It was just off the charts. And we had been off the charts for years. And the United Way, which is a large funder in the community, and our city health department pulled together a summit of everyone who worked on the issue. And when they pulled everyone together, they recognized 2 things. One is almost everyone working on the issue served girls, and they realized there was another part of the problem. And the other thing they recognized was that when they looked at data together on the issue, one of the data points that seemed to surprise everyone was that the majority of teen births in Milwaukee, the father was over 18, and they realized there was another problem in the community none of them were working on. Together, they identified 3 strategies, and they began doing them at scale. One of them was a massive public relations campaign that at times was very controversial, but also got a lot of attention and changed the conversation of the community. But the reality is that over the course of the years, there was a substantial and significant drop in the rate. And while the national rate was going down, the Milwaukee rate plummeted. This data is still a couple of years old, and I believe as of now, we are now very close to the national average from, again, 2.5 times that rate, while the national average has fallen. And that's what collective impact's about. It's not about let's all collaborate in a new way, let's find ways to connect. It's about how do we actually solve problems together? How do we create system changes and population level change, move needles, if you will, that have been hard to move. And typically what we've thought of in terms of collective impact are 6 elements that I think are really important. The first is a common agenda, that there's a set of strategies, a purpose, as Cherie mentioned, that really drives action together. And that agenda to be effective must be at the complexity and the scale of the problem, and must be really specific about what the work is that's going to need to happen for us to move that needle. And everyone has to be participating in the creation and development of that co-design. Once you have that agenda, you have to have ways to know how you're doing and to measure change in real time and be able to see what you're doing. And so there have to be ways to share data and guide work through that process. So in the Team Pregnancy example, they look at data on a regular basis. And in the early years, they were noticing that the rate for the Latino communities on the south side of the city were not falling at the same rate that the African American and white communities were. And so they created new strategies and adapted their work. And so the idea of shared measurement is not shared measurement so that you can write reports. It's measurement so you can adapt your work and change your work as you go to make sure you're doing the most impactful things to create change. The third is aligned partner action, which is really about how do we get people moving in the same direction. We often have multiple organizations, and I think this goes to the networks Rachel was showing, but we often have multiple organizations serving the same family in the same neighborhood who don't talk to each other. And how do we get people moving together to implement strategies together across organizations that, especially when dealing with the same neighborhoods and families, to move people to more successful outcomes? And so then the life of the person, it's a seamless system they're part of, not a bunch of isolated programs and efforts they're part of. To do all this, you have to have continuous engagement, ways that people are brought together, the ways that communities engage as a full partner in the effort, not community engagement as a way to kind of like get some input, but community as part of the production system of outcomes. How do we think of really, how do we engage community and partners together and make sure that everyone's getting the information they need, that we have meetings, that we have inclusive processes, and all of that to do the work. And to manage all of this, we've understood that we need a backbone staff. We need a staff whose job it is just to facilitate this work. That their job, they might be at across organizations, but their job is to facilitate the creation of the common agenda, to gather the data to support shared measurement, to coordinate organizations, to align their action, to keep people continuously engaged. But I would argue there's a 6th element that's actually a foundation for the rest, and that's a leadership culture. That there's a famous quote by the management guru, Peter Drucker, that culture eats strategy for breakfast. And what we found, and what I've certainly found in my work, is that you can have a great agenda and ways of measuring it and an initial plan to align people and communicate. But if you don't build a culture that is inclusive, that is equitable, that is accountable, that values learning, that enables people to be vulnerable in this space, if you don't build a leadership culture that supports this work, it will fail. And so I always say in building collective impact, it's kind of a twin engine plane. And one of those engines is building an effective strategy and coalition to guide it. And the other is building a culture to support that group of people to work well effectively across difference to make change happen. So that's my basic intro to collective impact and what is, and happy to answer some questions and follow up with people as well.
That was awesome, Paul. And as we've talked, I think there'll be an opportunity for us to have some further conversations and just benefit from your experience and wisdom, and especially in that leadership and culture space. I think, yeah, certainly that 6th condition is adds value to the whole framework, from what the little bit that I've learned. Got a couple more slides and then we're going to jump into questions. We've already had some questions come through that the panel are very efficient and are already answering, which is great, but we might share some of those responses for our wider audience. But let me just share my screen and let me just get to the next slide. From a collaborative perspective, what we are looking to do to support networks based around a collective impact framework is to create more of a resources to get people started. I guess the collaborative works in a way that we provide, or Dr. Andrew Miller would say, we take the best ideas and we share them, we steal them, we share them, so that nobody has to reinvent the wheel. So this slide here is our healthcare home model of care, 38 characteristics, where there are over 300 resources that sit behind, but very much that frontline focus, those that are on the ground making the change. And we've often been called that vehicle for change and implementation. The red circle there is, it's a bit small to say, sorry, but we do have a characteristic around community health networks. So we're wanting to build on that. So already, if you click on our interactive model care, the link is at the bottom, you'll see it gives you a bit of an overview. It actually includes a lot of toolkit from the Collective Impact, because that's all open source from the Collective Impact Forum. But what we're trying to do, and this is very early development, is say, well, from a New Zealand Aotearoa perspective, we have whānau at the centre, and we have our networks. What is it we need to provide, again, for those that are on the ground, doing the doing in terms of creating a charter, creating an MOU, and it all sounds like these are pieces of paper, but those at the front line need to be, I guess, supported when they're rolling out this. And certainly from my small involvement in the Kapiti Health Network, being part of helping create the charter, the memorandum of prioritisation framework, certainly to when Paul talked about the aligned actions, partner actions, how do you prioritise those based on the data and need within your community, just so that we are most impactful. So I don't want to talk much longer, only to say watch this space. There will be more resource coming, but we'll talk to our network to see what is needed as well. So that actually brings us to our Q&A session. And as I say, we have some questions already being put forward. So I'm just going to open those up, and we've got one here from Jeff asking, the Health and Disability System Review talks about a shared care record for patients as a priority for all providers within a community health network tier 1 services. How do we actually achieve this? Now I'm going to ask Rachel that one. I know it's a tough one, and I know there's been lots of work done in this space, but it is, again, restating what Jess has said, it is absolutely vital. What are your thoughts, Rachel?
So there's a number of things that come into play here. One is the interest in partners in sharing records and sharing information. You have to have a highly motivated group of people who are saying, actually, this is a priority for us to be able to practice well. I think we have been overly reliant on somehow the perfect technical solution that's going to come along and create this very simple, smart thing that's going to work for all of us. But in fact, we need to, and we are being critical about what is the information that we need to share. What is it that people need to know to enable them to make the next best set of decisions? Certainly in our primary care environment, moving to the Indice platform has been really useful because that potentially has greater utility. We know that one of the things we are thinking about is what is our investment to support our NGO partners in being able to create really sophisticated, much more sophisticated clinical records as well. So there is no perfect answer. It is a priority for us, but we are clear that we have highly motivated partners. This environment of trust is really important in this environment. Our PHO has been a leader in sharing records with patients so that they can actually see what's written on their records. That's part of this environment. So we're confident that there will be a place. But I think also we can become overly reliant on expecting that technology to deliver the ability to deliver care differently. So some of the smaller changes are important. The ability for Wellington Free Ambulance to share records prior to bringing someone into an A&M, into a general practice or into ED is something we have underway. That means that we are making better choices and decisions and not waiting for the perfect. So it's not a comprehensive answer, but it gives you a sense of what we're trying to build here and the realism that comes into that. There isn't a big bang solution.
Thank you, Rachel. Yeah, it is a tricky area, that's for sure. We were just talking today that the conversations have been go back quite some time, but I'm sure we'll get there. There's certainly a drive, I think, now to take it forward a bit faster. Now, Chris, we have a question from Gary around measure and outputs. Is there a factor being built into evaluation for measuring outcomes, and from the patient's perspective as to what has worked well for them and how health interventions have made a difference to them and their whānau? No, did you freeze, Chris?
And I have to start by saying that we're early days. The thing is that we have the PHO HITCHA. Freezing, my connection might be a wee bit unstable. We've got a large amount of data. The question is, how do we use that to answer the questions that we want? Speak.
Oh, Chris has got a connection issue. We might come back to that. Now we've got one from Joe. When is Paul next to New Zealand? Oh, do you want to? Sorry, Chris. Do you want to give it another go?
Right. Yeah, this is the one about data. So we're still in the process of developing a framework around that. The PHO has a large amount of data and has collected a lot of data, right down to line data for consultations, and can chart it all by geographical location. But we really don't know, we haven't really clearly articulated what the objectives are and what the measurements around those objectives are. We've just appointed a data scientist, and that's a big piece of work for the next year. So no answer for that at the moment, but watch this space.
Oh, thank you. And I think Joe was saying that when is Paul next in New Zealand? I guess when will our borders be open is the big question. He would be an amazing connector between primary care practices and PHOs attempting to understand the initiative collective impact.
I would love to come back. I haven't left my home in a year, except for going to the grocery store and a couple errands, and haven't been on a plane since March 6th of 2020. So would look forward to the day when I can actually go places again, other than my home and my office. So would look forward to that opportunity. But otherwise, glad that Zoom works reasonably well. And it is still mind-blowing a way to think that as a child I watched cartoons that said that people could talk to each other from around the world on video, and now we just do it like it's nothing. So
yeah, I was reflecting today that it must be almost a year since our New Zealand lockdown. Yeah, it's gosh, that time's gone fast, but how the world has changed.
Yeah, ours was March 12th, so this is the week.
Yeah,
that's
and
right.
So our president's going to address the nation Thursday night, which is the 1-year anniversary of when our nation started shutting down. So
yeah. Now, Rachel, I see that you did answer a question around, can you share what worked and what didn't in the efforts made so far with consulting and maintaining ongoing communication targeted specifically at general practice workforce at an individual practice level versus by the PHO? Do you want to just share that for the wider audience?
So one of the things that's really important is having a local team. We have a really strong PHO and a really positive working relationship, but you have to do it with a local team dedicated to that community health network, working with those practices, those people, those providers. It can't be a distant or abstract thing. There's a very intentional focus on building local capacity and capability. And so that probably is the thing that we see as critical in building that trust and communication at that local level with individual people and with individual practices. It's and also that the local, we have a sort of an establishment governance, as we call it, and that they can see the role of mana whenua and the role of people like Chris as a local person. People can see that it represents their locality and is not some imposition from outside of the Kapiti district.
Thank you, Rachel. And Cherie, again, you've been quick off the mark, but if you could share with us, how do you suggest the phonocentricity and effectiveness elements are evaluated?
So what we designed, well, we put in place the whare tapu whā. So what we've designed around that is a measurement tool that the 4 pillars are identified, and then when whānau come in, let's take, for instance, the project that, or the program that Horatai is doing at the moment. So whānau come in and their health needs are recorded, but also their social needs and their spiritual needs and their whānau needs. So we've developed that. It's also by utilisation, and we developed that model, and it was benchmarked on a lot of data that was already existing. So we gathered all that data together, or advised those that had the data that this needed to happen. That was gathered together, and it provided a benchmark for us to go by.
Oh, thank you. I'm just going to take probably one more question, because I am conscious of the time. We were going to run later, but given that it's now almost 12:30 in the morning in where Paul is in Milwaukee, we'll take one more question, and by all means, on your registration email, you can send in some questions and have a follow-up. But I'll take one more, which is, and Chris, I might get you to answer this one. How did you decide what is a priority in your community in terms of needs? Where do you start?
That's interesting, because there was some immediate need being generated by some local groups who identified some particular needs around services and travel into Wellington. But other needs you have to go looking for. And I think the engagement with the iwi has been particularly helpful in uncovering some of there's always unmet need, but unknown unmet need as well. So it's not just what's on top that's important, but it's engagement with the population to be able to draw out what they actually really need, and not just the ones who make the loud noise. But there are a lot of people who are, if you like, suffering in silence, who you have to try and get them on board and try and understand the community as a whole. It's really quite difficult. We've got lots of data, but how to turn that into wisdom is a big job.
Absolutely. We are going to jump into our final slides. But as I say, by all means, email some additional questions. I know Rachel has another meeting to go into, so make sure you look after yourself, Rachel. It's a long evenings, obviously, that you're working. I'll share my screen. So just in terms of a call to action, and I'll ask our panelists to just finish with some final words of wisdom. The call to action is really about starting the dialogue, having those conversations within your community, and many have already started. So what we would say is hold those real courageous conversations. They are difficult, but have those honest conversations about what the need is. And as you say, Chris, often it's those that are on the quieter side that can be overlooked, but so it's worth, getting creative about how we have that dialogue. Strengthen our relationships. Whakawhanaungatanga, that connectedness, that's certainly been a learning journey for me. And the more connected you are with individuals, groups, then the greater collaboration. Now, the collaboration moves at the speed of trust was something that I picked up from the Collective Impact Forum conference last year, and it absolutely resonates. We certainly get things done if you have a trust and relationship with an individual. You pick up the phone and say, hey, can you help? If they trust you, they'll move mountains for you. And then share the learnings, the good, the bad, because the good, the bad, the ugly. We don't want people to have those same mistakes being done in their communities, because you can have a great framework, a great set of data, but there could be things that are just not going that well. I think it is important to share. So on that note, in terms of Māori proverb above, what is the most important thing in the world? It is people, it is people, it is people. And I think that rings true for everyone. So I'm going to ask the panelists to just finish off with some words of wisdom or just final thoughts before we do our closing karakia.
Well, I'd just like to say that creating this environment in which we really focus on partnering with our communities has to be a priority if we really want to change people's outcomes. The health system in itself has a contribution to make and a role to play, but we have to see ourselves as partners. And it is a real privilege to work with the team in Kapiti to do this, and recognising that we are here for the long haul, and that we actually must make investments that are about growing and scaling service responses that work, but also be willing to stop things that don't work. And I think we've created something that is brave, but also just basically logical and effective. There is a little story that I will tell that I often forget to tell around why we started this thing. When we identified, I think it was 1,500 people a year, Chris, coming down to Wellington Hospital from Kapiti by ambulance or by air and going home on the same day. And when we looked at that, the harm that causes to families and individuals is one of the things that we see. So you can get flash on your outcome metrics, but as Chris pointed out, you can just change some really simple things that make a difference for people. And I'm sorry I need to sign off now to go into my next Zoom, but thank you very much to everyone for joining.
Thank you, Rachel. Really appreciate your time. And Paul, would you like to share some further wisdom? I note your website details, thank you, and I will pass on your details to our network as well, because I think there's definitely some support you can provide us just in terms of your knowledge and experience that can be transferred into New Zealand.
Yeah, thank you. And again, it's always great to learn and to be part of these conversations. And thank you to the other panelists and to you. And I think, again, my main message for all work, whether it's organizations or networks, is that strategy and culture have to be built together. And it's something you've brought into the conversation as well from the beginning today, but you have to create an environment that builds trust, that builds inclusion, but also builds accountability and learning and all of that together. But good strategy makes it easier to build good culture, and good culture helps you build good strategies. So to me, it's something that you build together and makes this work far better. So thank you, everybody.
Thank you.
Good night.
Paul. Good night. Sleep well. Cherie.
Yeah, I just want to just remind everyone that relationships link us together. They build and can support shared values,
Yep.
And they are at the centre of everything.
Yep.
Kia ora.
Kia ora. And Chris.
Yeah, look, I would echo the thing about relationships, but building relationships takes time. The other thing I'd say is that for a long time, the health system has been designed for the good of the providers, and we really need to make it designed for the good of those that need services. And that's one of the lessons I think we're learning in Kapiti.
Thank you. Now we'll close with a karakia. Let's move on to our final slide. For more information, there's our website, and also we have another webinar on the 15th of April covering consumer engagement involvement in terms of how organizations need to work to involve the consumer in their decisions for design. So watch this space for more information there. Thank you to our panelists. Thank you to our audience this evening. It has been really informative, and I'll look forward to rewatching this. Again, and drawing, you know, those learnings, deeper learnings, and having some good conversations. And then let's close.
Kia tau ki a tātou katoa, te atawhai o tātou areke o ehe karaite me te atua, me te aroha o te atua, me te whiwhinga tahitanga ki te wairua tapu, ake, amene.
Good night.
Thank you, everyone.